Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. I'm actually in Napa today, and I'm recording kind of last minute before we head out on our wine tour today. So pretend that you're here with me, and hopefully you appreciate what we're doing here. So before we get started, I want to let you know the CodeCast podcast is brought to you today by Just Coding. Calling all medical coders. Want to stay ahead of CMS changes, sharpen your coding skills, and earn CEUs all in one place. Just Coding is your go-to resource for expert guidance, coding quizzes, and exclusive tools. Save $5 on your subscription today at hcmarketplace.com/justcoding-.com. Enter code SAVE5 and to take your coding to the next level. Okay. Also, if you want information on, all the changes and everything, don't forget I do have a Medicare, two of them actually, Medicare first quarter updates, one with the NSCHBC next week on the 25th, nschbc.org, and then one with McVeigh seminars to follow. So I have one at 8 a.m. Pacific, one at 10 a.m. Pacific. And don't forget that pesky telehealth. Those are the 26th and the 31st with the same companies respectively. So take a look at those if you're trying to get some information on what's coming up through the first quarter and what's coming up April 1st for telehealth. So today is going to be kind of a mixed bag of some updates that we recently received. And we want to make sure that you have them. One is for ICD-10. We got an official update yesterday last week, an update to the ICD-10 official guidelines for coding and reporting. So this is basically, they tell you how to use the ICD-10 codes, the CM codes. And these will take effect April 1st. So you're kind of the first people to get this. The following three changes are particular importance to CDIs, so, documentation integrity, and coding professionals. I recommend reviewing the entire document. It won't take you very long. But as a reminder, the CDC does us a favor by bolding these changes. And I'll have a link on my website as well as a short, probably blog, just so you have it. So for COVID-19, so in short, a positive lab test for COVID-19 is not going to be any longer sufficient to report the diagnosis. So per the update, there's what they say, for asymptomatic individuals who test positive for COVID-19 and there is no provider documentation of a diagnosis of COVID-19, query the provider as to whether or not the individual has COVID-19. A false positive laboratory test is possible, and it is the provider's responsibility to confirm the diagnosis and document accordingly. So that's actually a pretty big update. Remember back in 2020 how just, you could look at the patient and they said, oh yeah, you look like you have COVID, so let's just give it to you. Boy, we've come a long way in 5 years. The next topic is obesity. As a reminder, again, effective October 2024 last year, the CDC added obesity classes to E66.8. So they have other obesity, and these included class 1, 2, and 3, E66.811, E66.812, and E66.813. Again, class 1, 2, and 3. And then they have the E66.89, which is other obesity not elsewhere classified. So what the new codes lacked, they now have guidance. The guidelines instruct coders to report class 3 obesity instead of morbid obesity if both are documented. And as they consider this to be a little bit more specific, they actually go on to say the obesity class is a subcategory. E66.81 require fifth character to convey the severity of the obesity. The obesity class should be documented in the medical record by the provider for these codes to be assigned. So that's important because your physicians aren't used to documenting the class, and I'm air quoting, when it comes to obesity. But make sure you're looking in the ICD-10 chapters 4 and 15 to fully describe the condition. But in both class 3 obesity and morbid obesity, when they're documented, you're only supposed to code for the class 3 obesity, should be assigned as they feel that it's more specific, and I have a feeling this is going to be also tied to reimbursement. So that's important, especially if your patient is receiving any kind of medical nutritional therapy, and things like that. The obesity codes category E66, overweight and obesity, includes codes related to the cause of obesity, such as drug-induced obesity, that would be E66.1, and codes related to the effects of obesity. E66.2 says morbid severe obesity with alveolar hypoventilation. There are other codes related to obesity in other categories. Look at E88.82, that talks about the disruption of the MC4R pathway. And they actually have a fifth category, a subcategory, I should say, the O99.21, where obesity complicates pregnancy, childbirth, and the peritoneum. So make sure that you're looking at all of that when you are trying to classify obesity, because I feel like it's used as a generic, secondary diagnosis, sometimes primary, and now you have to get more specific if you want things covered. And then lastly, for the updates that I'm just going to talk about, really talk about sepsis due to a post-procedural infection. I've had a couple of those that I've been dealing with on audits. So it says for sepsis following post-procedural wound, surgical site infection, you're going to use a code from T81.41 to T81.43 for infection following a procedure, and then T81.49, infection following a procedure, other surgical site. And then in the O section, the obstetrical section, I should say, there is O86.00 to 03 that talks about obstetrical surgical wound, and then the other surgical infection for the 09. So it identifies the site of the infection should be sequenced first if you do know it. And then there are some additions to just make sure you know that the additions would be the T81.49 and the O86.09. And that just gives you that other, it's specified, but maybe it's not clarified within the note. But those are important, updates to have when it comes to making sure that you're well educated on ICD-10 if you're the one choosing the codes or talking to your physicians as well. Now, I also wanted to comment on a couple of resources I found, because we continue to bang our heads against the wall. At least I do. I'm sure most of you do too, when it comes to medical prescription drug management. How many times does your doctors just say, they list the drug and then they just say continue, and they want to get this moderate medical decision making? Well, there's an AMA resource, and it is let's see, I'll put it on my website as well, ama-assn.org. It's a system file, and it says 2021-06, but it basically complements the 2021 new guidelines we got, but it's called an update moving forward paper, and it's on the bottom of page 4. And here's some of the quote. It provides clear guidance on reporting prescription drug management supported documentation. And here's what it says. Physicians should make a direct connection between the medication that's prescribed to the patient and the work that was performed on the day of the clinic visit, such as, quote, stable hypertension, continue valsartan 10 milligrams, will refill for 4 months until next follow-up visit, unquote. Simply stating that the medication list was reviewed will not meet the definition of prescription drug management, end quote. So they put that in quotes, just listing it, you don't get it. And I'm seeing that quite a bit, and doctors are like, well, it's there. It's like, no, I have to follow the trail, and I'm looking for management, not just a list. Otherwise, that's just part of the history. And then always keep in mind, too, when we are looking at the risk of complication and morbidity and mortality, when we're looking at the third element of the E&M. And I mentioned this probably a couple weeks ago when I've kind of been breaking down some of the elements there that I'm noticing aren't really kind of still understood of what they're talking about. AMA CPT guidance is really clear on this, but I think sometimes it's tough to have people understand it. So the risk of complication and or morbidity, it says a state of illness or functional impairment that is expected to be of substantial duration, during which function is limited, quality of life is impaired, or there is an organ damage that may not be transient despite treatment, or mortality of patient management. So this is where, recommending things that are not considered treatment or that are preventative, like, sunscreen or something like that, unless it's specific to a patient who's had cancer that you're trying to say sunblock versus sunscreen. There is a difference, by the way. Then how can you say that it represents any kind of risk for that patient if it's more of a public service announcement? And so you have to be careful with putting public service announcements or general health information in the patient's medical record and thinking you're going to get credit for a high risk or a moderate risk on that patient. Maybe straightforward, but it's really hard to get anything higher than a 2 or a 3, and I'm seeing that all the time. And remember, don't just stop at AMA. Look at CMS, look at your specific MAC carrier's guidance. I found, information in the Skin Cancer Foundation, and the reason I bring up sunscreen is that it always seems to be an issue. And that it says right there, reports sunscreen is used to prevent sun-related skin conditions like sunburn, prevent premature aging, reduce the risk of skin cancer, but it doesn't say to treat it. And so doesn't say, that it is a risk of morbidity and mortality if you don't use it. So it's more of a risk factor reduction, preventative, again, annual well visit or preventative. But if you say something that's specific to a patient who has a history of cancer where you're giving them options, because some sunscreens are chemically inappropriate for certain patients. So you have to go to block or you have to go to a prescription part of that. That's different. But some of these public service announcements or, you should eat your green leafy vegetables, that's not a risk there. So be careful when you're instructed to give general health information to a patient and think that you're getting any kind of, low, high, moderate risk out of that, because that would be incorrect. And that's not just an interpretation of the rules. That is, a stated fact within the rule, and also some of the payer policies that are being, dissected now from payers saying you're trying to get money that isn't okay. Now, next week, it's a top 10 Tuesday. I do want to talk about, let me rephrase. I don't want to talk about it, but I will. Advanced care management services, because there's so much confusion out there, and I feel like people are using that as a gym membership and, saying that it doesn't matter if the patient uses it or not, you still get to bill for it. Absolutely not. I mean, there's a good publication out there with Betsy Nicoletti's, she has a booklet on it that I like. I've written up a script on it. I know that American, Academy of Physicians has done it as well. The AAFP has done it, the American Academy of Family Physicians. I know Christine Hall has a great publication for CCM. And remember, chronic care management, primary care management, and now the advanced primary care management codes. These are all very intertwined. And when you look at the final rule, it says we have similar, insights, similar functions, similar language, and then they just give what is different. And I even, have a matrix on it. If you're a membership client, you can ask me for it. Don't forget, we do have that Coding Corner membership, and you get a lot of different information sent to you. So just make sure that you tune in next week, and if you are utilizing this service, that you are being very careful about that, because there's a lot of documentation and administrative work that goes into using those services for the money that's there. And I'm starting to see more and more physicians just enroll patients blindly into these care management programs. And do they really need it? You always have to go back to medical necessity. So before I go any further with that, I will definitely talk about that next week, and hopefully you'll find that podcast helpful. All right, I'm off to my wine tasting for our day 2, and we're having a good time so far. A little cold up here, but we're having fun, and it's always nice to be with family. So hope everyone has a great rest of your week. Make it a great day, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.